Good afternoon, everybody. Welcome to Weekend University this afternoon. What we hope for these conversations is that they provide some information and they maybe help you understand something. But the point of these is that you're provided a seminar. We have some experts leading us today in this conversation. And then at the end, there's Q&A, obviously, at the end. But what we hope is that if there needs to be more conversation for you, those folks that we have presenting today are available for that, but also their resources and their contacts are available for that as well. So they'll present on some topics, and then they'll provide space for feedback today. But the point of Weekend University is to hear some experts and then seek out the next steps in conversation if that's what you're looking for. And so with that in mind, I will invite our presenters this morning. They can introduce themselves, so we'll go for that. Thanks, Joel.
Well, good afternoon. My name is Joel Roos, and I'm the clinical director at the Collaborative Care Network. I'm a psychologist here in town. This is my colleague, Kelsey. Kelsey, why don't you stand up and give the folks a wave? She's going to speak a little bit later on today. And we are here today to, receive this great invitation from Kensington Commons to engage in their Weekend University program and talk with you guys a bit about mental health. You probably have no idea what the Collaborative Care Network is. That's okay, but we're a small private practice here in town of mental health care practitioners and educational consultants that, largely work with people with specialized needs around mental health. We design programs for them and counseling and one-on-one clinical work, and to that end, we love doing public education and are excited to talk with you guys today. So just in introducing ourselves, we also kind of want to introduce our format for this. We're hoping not to engage too much in just being a talking head up here. So we'd be really honored and quite accepting if you wouldn't mind throwing up your hand, and if something we say kind of catches your attention or you'd like to provide some feedback or ask for an expansion on something, we're certainly willing to do that. We do want you to be aware that I believe we're recording our presentation today, so I'll likely repeat the question back that you ask out, just so the folks who check out the recording later on will have a chance to hear what's being discussed in full. As Pastor Joel mentioned, we're going to have a Q&A at the end, and you are welcome to save your questions to that point in time if you'd like, but know that this material is supposed to be a little bit thought-provoking, and so certainly if you'd like to interact with us, that is what we're here for. I'll just give you a brief overview what we're hoping to cover with you today. We do have a fair bit we're going to go through, and somewhere around the middle we are going to take a quick break just for coffee refills and grab some of those snacks out of the snack table, just because 2 hours is kind of a while to sit here, even if you are talking and asking questions. But we are going to start by talking a little bit together as mental health, what mental health is as a concept. I was just joking with Kelsey right before we began this afternoon that, it's the 21st century. I said to her, I guess everyone's got to be talking about mental health these days. It seems to be in vogue. And in reality, it kind of seems that way. You can't go too far without turning on the news or reading something online about, this study about mental health, or this is a mental health issue, someone says in the news. So we're going to talk about actually when people start to use these words and phrases, what does that actually mean? And what is that? And what are we actually referring to when mental health professionals joke it's the 21st century, everyone ought to know about this stuff? We're definitely going to talk a bunch about depression today, because when it comes to mental health, depression is one of the big bad ones. We're actually going to look at some of the numbers about how this impacts people in Canada and globally, and recognize that there's things we ought to know about this particular area of mental health, because in all likelihood, if this hasn't touched us personally, it's going to be touching or will touch someone that we know personally. And similarly, along with depression, we're going to look at something called anxiety and the anxiety disorders. And this is another area This is another area of mental health that is widespread in youth and adolescents. This is actually the #1 mental health concern, period. And again, the rates here and the numbers here are kind of shocking. And we're going to look at a few of those together and see if we can understand a little bit better what this is exactly and how it works and what we can do about stuff like this. And overall, Kelsey is going to kind of transition us into talking a bit about how to help the people around us. Because whether or not mental health is kind of like a new language to you, it's something that you're just learning about and learning how to talk about, or whether it's something you're quite familiar with because of personal experience, or again, the experience of those loved ones around you, or the people that you know, how to help those is something that gets a little tricky. Even if you know what you're talking about and what you're thinking about, because sometimes we get this impression that the only people who can be helpful with mental health maybe is a counselor or a psychologist or a doctor or something like that, when actually the truth couldn't be farther from that idea. And beyond just how to help those around you, we're going to talk a little bit today, and Kelsey's going to also help us understand maybe how we can help ourselves. Because just as it gets a little confusing, I think, to figure out how to help those around us, it could be equally problematic to figure out how to help yourself when one of these weird things or these mental health issues are coming up in your world. And obviously, we're reserving some time for Q&A, because often when we talk to people about this kind of stuff, it just raises questions, okay? So this is kind of the up and down of our couple of hours together this afternoon. And that being said, let's begin our conversation. So the word mental health itself, hopefully you understand, has a stigma attached to it, just by way of watching television or movies or, reading books or, reading maybe articles or something like that. All of you have likely had an experience in your life of at least someone else's stigma of mental health, even if it's not your own. And so some of the things certainly that you would be exposed to is this idea that mental health has to do with insanity and craziness and, kind of chaotic imagery and experiences. And if you know anything about our history, culturally or historically, you may understand that in the medical system, mental health has a history even in the recent, say, 50 years, 60 years. That includes things like psychiatric hospitalization and the mistreatment of people, certainly things that in the 21st century we would find very appalling with our current kind of ethos of people care and things like that. Realistically, all of you have probably been exposed to a caricature of mental health somewhere where the idea is somewhat jokingly applied that mental health just has to do with, people going a little batty or a little nutty or crazy. At the very least, I'm sure you've been exposed to jokes like this, maybe just around the dining table at a family dinner or at a social function, right? Someone just makes an offhand remark about so-and-so went a little nuts, or, they're a fruit or a vegetable, like our little cartoon shows up here on the screen. Whatever the stigma level you may be aware of, maybe today is the first time you even knew that people had these kinds of thoughts about mental health. Whether you're aware of it or not, these are some of the prevalent conversations that seem to happen in the background in society around mental health. They kind of pop into our view and they're there on the surface, and they maybe come across in a joke or in an image or in something artistically portrayed through a TV show, and then not much else is really said about it sometimes. And I think this is how mental health actually gets a stigma. It's interesting that, Kensington Commons is hosting this Weekend University series to open a conversation about mental health, because if you study Christian history and church history in North America, you'll find that even the evangelical church streams of Christianity have had a checkered past with learning how to engage with mental health. It can be difficult for people to even reflect on their own church and faith experiences if you're old enough in this room to remember growing up in a church as a young kid like I did. I grew up in the 1980s, and mental health wasn't even a widely known concept 3.5 decades ago, let alone regularly talked about in faith circles. So, how do we approach mental health in the 21st century? Well, part of what we have to do is begin by identifying, like we said earlier today, what this word really encompasses. Mental health gets tossed around as one of those buzzwords and phrases a lot of the times that could represent a lot of things. Maybe it's going to be representing depression and anxiety like we're talking about today, but it can actually represent a lot of other things too. Mental health has to do with how your stress level is going. Mental health has to do with those fancy diagnoses you might have heard of or get tossed around, words like bipolar or post-traumatic. But day-to-day experiences where your emotions go up and down just because you're a little happy or you're a little sad, that has to do with mental health as well. So starting to understand all of these components of mental health can begin to give us an idea of, in the 21st century, what people are talking about when one of these things comes up in one of those articles we're reading. This is an interesting picture that got brought to my attention actually by Kelsey, my associate here. I think she actually uses it in one of her slides later on too. But there's a little bit of word art that seems to be describing or filling the faces of these two talking people. And on one side, the left-hand side of this picture, the word art seems to have a bunch of negative words. And on the right-hand side, the word art seems to contain what seems like helpful or intervention type words or receptive words or positive words. And there's a meaningful interaction in this little metaphor, this pictorial metaphor for me, because it seems like so much of what mental health involves in the 21st century is talking. Is ideas that may not start the same from one person to another when they begin to talk, but no matter what's going on with someone's mental health, it seems like it always gets shone out through the lens of a relationship, whether it's the relationship with somebody else or those around them, or a relationship with yourself. And whether the talking is loud or it's that wonderful voice we all have in the back of our head, and just that kind of talking, mental health really can be summarized, I think, by the way this particular graphic artist, has tried to express something in this image. So as a psychologist, I have a particular view of mental health because of what I do for a living. Being a psychologist is kind of a confusing thing because I find myself even having to explain to people what that means quite often. I am most often confused for a psychiatrist, I think, which is a whole different kind of person. Psychiatrist is a medical doctor who's studied about brain chemistry and brain medications and how those things interact with mental health. As a psychologist, what I do is I work in the expertise of human nature and how that works. And rather than go to something like a professional school like med school, I had to go to university for a certain amount of years and study a certain amount of things, and then take all that knowledge to a licensing board and have them kind of stamp it and approve that I learned enough to be able to call myself this. But in the area of psychology, what they focus our study of the human nature on is essentially how people think, how people feel, and what they do, how their behaviors might be like habits and rhythms, and how all three of those components, how people think, feel, and behave, tend to interact with their physical bodies and brains and actually change those things. As a young psychology student, this was news to me, that the way that I think and feel actually created chemical and electrical change in my body. I know sometimes you may have heard this thing called the mind-body connection. It gets a phrase that gets thrown around an awful lot, but what's interesting in my field is you start to learn the science of how these things work. So as a psychologist, I often look at mental health through the lens that I'm most familiar with, and that's trying to look at it through how humans experience mental health with their feelings, with how they think, and with their everyday life, what they do. And so I have a little acronym that I was exposed to rather in grad school that has really served me well. And I actually keep this running in the back of my head, even in my work when I meet with a patient or a client for the first time, and I start to assess in my profession what's going on with their mental health. The acronym is BASIC. It's very basic to remember. Insert laugh here. Come on, folks. You're alive. Thank you. I appreciate that. All right, but BASIC stands for, the first thing I look for is what's going on with their behaviors, the behavioral aspect of their world. So I start to look at, is there any distress or problems with their day-to-day habits, their rhythms, the things that they're used to? Believe it or not, again, this might be news to you, but when these things change in someone's world, there's chemical changes that happen in your body. There's electrical changes. There's psychological and thinking changes. So your day-to-day rhythms changing has an effect on your health. It certainly has an effect on your mental health as well, too. And so we absolutely look for any signs there that things are not as they should be. As a psychologist, we study affect, or the emotional side of things. Affect is just the fancy technical term for that. But the affective piece is when people describe their feelings with both qualitative and quantitative words. This is the kind of feeling I'm having. I'm sad, I'm glad, I'm mad, I'm angry, I'm tired, I'm unheard, I'm betrayed, I'm lonely, I'm the whole range of human experience. And the amount that people have these feelings, there's a typical range that we would expect humans to have all of these feelings in. And when their feelings go outside of that typical range, that's a signal to someone like me that something is going off, that something's wrong. And a lot of times we live in a society where things like emotions have previously been trivialized. You know, they've been described, I think, to us sometimes as the opposite of reason or the opposite of logic. So they must be bad or they're just problematic, right? Because they come up and we don't want to deal with these things as they're coming up. But particularly in the study of psychology, we're quite interested in the patterns of emotions. And certainly with mental health, it's something as a psychologist I like to pay attention to. What's going on with that in people's worlds? We look at what's called the somatic, which is just a fancy way for saying the physical. What's going on with the physical body? This is the study of psychology. In order to get licensed, I had to prove I knew about what's called the biologic basis of behavior. There's a huge test I had to write, and I had to score high enough on it, and I had to tell them about brain chemicals and neurons and how the nervous system works and all of these things, because that part of you is intricately connected to how you think and how you feel and how you behave. On top of my work with collaborative care, I work for the public health system as well in a couple of the hospitals around town. And I often find myself explaining in the hospitals to people, they say, I can't believe I just, changed my thinking a little and I started to feel better. My body started to not be as sick. And I explain over and over again, you have like 50,000 thoughts a day, right? Every one of those thoughts is an electrical impulse, and your body and brain doesn't know the difference, whether that impulse came from you getting poked in the leg or it came from your brain thinking a thought. To your body and brain, it's just another electrical impulse. So of course, if you change your thinking and change your experience and you change the direction of 50,000 thoughts a day inside your body will respond. To those of us who study this is not new news, this is not new science, but I think in the public sphere, when it comes to a discussion about something like mental health, which can be difficult to approach and maybe something we don't even have a lot of experience talking about, this is new news. This isn't something that is on the tip of our tongues every day as we talk to each other. So the somatic piece of how life goes, what's your health like, what is your body telling you? These are things that we look for in the area of mental health. Interpersonal stuff, we look at how your relationships are going in the area of mental health, because relationships tend to go up and down in patterns as well, just like all of these other things, when things are going well or when things are not going so well. And then C is for cognitive, which is the thinking part, which is largely what a lot of people already associate with mental health. It has something to do with our thinking, with our brain, with the way we interpret and see the world around us. And that's absolutely a piece of your mental health, but it's not the only piece. So when we talk about mental health in the 21st century, as a psychologist, this is what goes through my mind. When I have someone who walks through my door for the first time and says, "Oh my gosh, I'm having a breakdown," that's usually the kind of language they're using. They don't come in and say things like, "I'm having trouble with my mental health today." It's just not the language people are used to using, I think, in conversation. But when they say those things to me, like "I'm having trouble" or "I'm having a breakdown," this is what starts to go through my head. I start to wonder what's going on with their behaviors, what's going on with their emotions, what's going on with their thinking, what's going on with their body, what's going on with their relationships, because probably the problems or what's going wrong lies in there somewhere. I think we're going to talk just a little bit about depression, and then after that we're going to take a quick break, and we'll resume together and to talk a bit about anxiety, and then look on with Kelsey at how we can help some of this stuff. But why we wanted to highlight depression and anxiety today for you when we look at mental health is because, quite frankly, it's the numbers. If you're going to run into mental health in your world somewhere, this is probably where you're going to run into it. You're going to intersect or have some kind of life event or experience, or a family or friend member, or a friend or family member who has depression or who has anxiety. So, some quick stats for you. 1 in 10 Canadians will experience a major depressive episode during their life. Okay, we're going to look at what that word means, but major depressive episodes means like a doctor or a psychologist like myself would stamp this thing on a medical chart and say, "We need to do something about this. This is not good." Okay? One of the top 3 causes of disability worldwide, and of course geographically it depends where you measure, so on and so forth, but this would be the World Health Organization, the WHO, who does this kind of recording in numbers, okay? So when we talk about disability, we're thinking about things like unable to go to work, unable to have relationships, unable to do day-to-day family life. Top 3 worldwide. Okay? Depression is not just a crazy in your head kind of thing to break some of those stigmas that we've been talking about. But depression is actually correlated, which means it comes alongside with a bunch of other big health concerns. And a lot of people who go through these other health concerns and life events aren't necessarily prepared for the fact that depression's coming with it. So we look at things like chronic diseases and health conditions. So this is my capacity actually in the public healthcare system, is that I work with people with chronic diseases and chronic pain. And depression and anxiety affect probably 80% of the people I work with there, because they're going through things like chronic pain or fibromyalgia or diabetes or multiple sclerosis or so on and so forth. Postpartum birth for mothers. There's a whole category of depression called postpartum depression. And actually the numbers for postpartum depression are scary. They're huge. Every single one of you in this room has a mother. That means your mom fit into those numbers. She was at risk for it. Maybe because of the societal change and what is okay to talk about in the 21st century versus what was not okay to talk about back then, maybe your parents went through it and you never knew. Maybe they went through it, and someday down the road in the 21st century, if your parents are still with you, you might even be able to ask them about it if they felt comfortable enough to have this kind of conversation with you. But postpartum depression is a huge concern. We look at something called social economic status sometimes in psychology, and that's just a very fancy word for if we take a bunch of public surveys and we measure how people do in society with wealth and how they do with health and how they do with life goals, we have something called the social economic status of society. So scientists and demographics clinicians, they study these things and publish these numbers every year, and we can actually track that people with lower social economic statuses in societies have greater risks of having a depressive episode. Similarly, things like substance abuse and addiction, social isolation, so even living alone raises the chance that you could suffer a depressive episode. Okay? Extended grief and bereavement. If you're like me and like most of the people on the planet, you can largely expect that someday you will have relatives who will pass away. That's kind of how life works. It's one of those very guaranteed things, unfortunately. And to that end, we'll all go through a grief process. We'll all go through some bereavement in our lifetime of losing those who are close to us and important to us. And actually, that period of your life puts you at more risk for suffering depression. Part of what I'm trying to... Yeah, please. Do you have a question?
Just a quick question.
Yeah.
How do you distinguish between what you call a major depressive episode versus, you're not feeling all that well? We've
Beautiful.
We've
Yeah.
been unhappy for a period of time.
Long time, yeah. The question was, how can you tell the difference between a major depressive episode and a period of time where you just haven't felt well or you've been down for a long period of time? Actually, I'm going to look at this with you guys in particular this afternoon, and we're going to go over what we would call the diagnostic criteria for depression. So we actually use a special formula to look at if, kind of items 1, 2, and 3 are happening, but not 4 and 5, but it is 6 and 7. We can kind of decipher, is this a major depressive episode? Is this just someone feeling down? And so we're going to look at that together. That's a great question, though. Thanks. So aside from things like grief and bereavement, we look at stress or trauma or these life transitions or even just feeling down, like the question was about, over a long period of time as being a risk factor for depression. But we are going to look at how depression is a little bit different from just being down in life. Important to understand that depression has not just physical symptoms, but it has physical symptoms. It has emotional symptoms. It has cognitive symptoms. When you are depressed, your brain actually changes the way you think, okay? And it has behavioral impacts and symptoms as well, too. So very important to understand about depression. There's one of the big stigmas and myths around it is that you can essentially will yourself out of it. That if you're suffering from it, the correction for it is somehow that you've just got to try harder in these areas that aren't going so well for you. And actually, because these things are actually impaired by the depressive disorder, that's impossible. You can't just try your way out of it. Okay? Other important thing to see, it really shows up in a lot of the literature and statistics and government programs that measure this kind of thing. But the biggest barrier to treatment when depression doesn't get taken care of people, it's actually because of guilt or misunderstanding around depression itself. Somebody gets depressed and they feel bad that they are depressed, and it actually, in part, prevents them from seeking out the help they need. They feel like maybe they're too strong for this and they shouldn't have been depressed. Or maybe they're doing everything right, so this doesn't all add up, or whatever it is. But that guilt and shame becomes sometimes the biggest barrier for people getting help. So, because this beautiful question paved the way for us, we're going to look together at what the diagnostic signs or symptoms of depression are, because this is actually how we figure out if it is a major depressive episode. We look for particular symptoms, certain things that are happening, and we measure them. We see how many of them are happening, how frequently are they happening. Okay? And that really is the sign that this is depression. This is news to some people. Some people go to their doctor first time to talk about something like this, or they suspect something's going on. They expect a blood test, or maybe to put their head in an x-ray machine or an MRI or something, because if it's in the brain, you should be able to get a picture of it, or something along those lines. But this isn't how we diagnose this particular disorder. We actually look at what's called a patient history, so finding out what's going on in your world, and we look at what's called patient report, so what you came to us to tell us is going on. And if it lines up with a checklist like this helps us figure out, is this what's going on with you? So the first thing we look for is pretty obvious, what we call depressed mood. This is that idea of feeling down or sad or kind of in the dumps or low, like we were asked about in the question. But it's important to notice that for adults, it's not just about feeling low. Actually, the most common presentation of depression in men is irritability rather than sad mood. So kind of being short and snappy and kind of, doing things maybe that you wouldn't commonly expect someone in that position to do. They would say things to you they'd never say. Maybe their temper seems to flare up in a way that you wouldn't expect it to. But really, it comes down to more mood regulation than anything. Because both on the sad side and the grumpy, kind of cranky, irritable side, it's like the piece inside of you of your emotion that usually keeps that in check isn't working. Okay? After mood, we look for something that we always call the diminished interest factor. So the activities that you've enjoyed before, the things that usually bring you pleasure or joy in your life, the leisure stuff that you do, the self-care stuff that you do in your world, if it usually makes you feel okay, it kind of loses its flavor. Or it's like, oh, you couldn't be bothered, or now it's such a drain to do that stuff. And so when that's the report, when people start feeling that way, it's an emotional symptom, obviously, but this is a sign that we're dealing with depression, okay? Weight loss or gain, or an appetite change. This is one of the physiological things that starts to happen because there's a big shift in people's, everything from the way their hormones get distributed to digestive things and amino acids and all the pieces connected with your endocrine system and with your autoimmune system, because it all hinges on your nervous system, which is just going haywire when you're depressed. Okay? So weight loss or gain is because the signal from your nervous system is telling those parts of your body either overperform or underperform. And so we start to see these changes in people's everyday life. Insomnia or hypersomnia, this is the idea that you can't get enough sleep or you can never seem to sleep at all. Okay? So either end of that scale, if we tend to start seeing people's sleep get disrupted, again, we know it has to do with the types of changes that are going on in their nervous system. Psychomotor agitation, which is just a fancy word for restlessness, or retardation, which is just the fancy word for slowing it down, okay? But when people's day-to-day, their movements, all right, so how they move around gets really fast and agitated, or it gets much slower and much more lethargic, or the way they're talking, maybe they seem to always be really more intense and a little bit faster, or maybe it's really just hard to get a single word out of them and you can really tell that they're talking differently. This is another one of the signs we watch for, okay? Fatigue, tiredness, loss of energy, one of the common symptoms of depression, okay? Feelings of worthlessness or inappropriate guilt, we see this come across in a lot of ways. For people, it's usually along their passions. Their passions and their biggest time sinks, okay? That's where these feelings will come up. So if you're passionate about something, it's very important to you, that's where you start feeling guilty or worthless, or your biggest time sink. So do you spend the most time in your week with your family or going to work or going to school? And that's where you'd see those feelings come up instead, okay? Diminished ability to concentrate, think, or make decisions. This is actually one of the scary ones. We end up seeing a lot of people with depression who report to a doctor or ER thinking they're having a stroke or thinking they need their head scanned or something's going wrong again. Because a lot of people, this may be the first time in their life they've had an experience where their thinking changes and they didn't do the changing. it happens without their permission. And all of a sudden they notice that they're thinking differently and they have these intrusive thoughts at times, thoughts that would rather not be there. It's a very disturbing experience for people the first time that happens. People think this is where, some of that language pops up, that they're going crazy or something like that, because it actually feels that way sometimes. Okay? And alongside of those intrusive thoughts can be particular thoughts of death or suicide or escape. And again, in our society, we don't often talk about these things. We can have a hard time actually talking about the end cycle of life where death happens and our typical response to it, mostly because we're uncomfortable in our society talking about mental health and emotions. These are just topics that are not our usual dinner table things or our, over a coffee with a friend. I don't check out with my buddy and say, hey, how are your emotions today? How's your mental health going? This is just not our usual rhythm. And so part of even opening these conversations in a forum like this becomes a normalization of sorts, the ability to enter into these conversations with a little more language and a little more skill and a little more understanding. And so what we look for in particular to diagnose depression is that we look for at least 5 of these 9 symptoms happening. Okay? That's the magic number. There's no right mix of them, and this is where depression gets tricky. And I think this is where some of the confusion comes in around depression at times, is because one person will have the top 5 symptoms on that list, and they're depressed. They don't have the bottom 4, just the top 5. Someone else will just have the bottom 5 symptoms on the list, not the top 4, and they're depressed as well. And then you get people who actually do talk about this thing over lunch, and they say, oh, I was depressed once, oh, I was depressed once, and they compare stories, and they look nothing alike, and everyone comes out of the conversation even a little more confused. But the up and down of it is, depression is such a wide-ranging thing when it happens to people that it does have multiple presentations. It looks different ways for different people. And so our diagnostic criteria allows us to capture that and be able to say, even if it looks this way for this person or this way for this person, we can for sure say, hey, this is depression. So what we're going to end on talking about depression specifically is, if this is what depression is, and this is how it happens, and these are all the shocking numbers about it that I'm introducing to you, what can we do about it? This is probably, along with what depression is and how it works, probably the most misconceived thing about this particular area of mental health, largely because it was one of the first mental health conversations that really came to the forefront. The late 80s and early 90s, with the advent of some new drugs, some particular antidepressant drugs, it became very popular actually for the medical community and mental health community to refer people towards medical treatments for depression. And to this day, there's still a group of family doctors who were probably trained in a certain era that if you go into your doctor's office and say, I'm depressed, the only response you may get from them is a prescription. And that's okay. That is part of the appropriate response for depression, but part of what you're going to want to do is be able to talk with your doctor in more detail about what might be necessary for you or anybody. The research and literature shows that the most effective treatment for depression is something called CBT, or cognitive behavioral therapy. This stuff is not just the sole province of counselors and psychologists. This stuff is done by doctors, this stuff is done by nurses, this stuff is done by occupational therapists, this stuff is done all over the map, but largely done by healthcare or mental health professionals. And it's largely just a group of exercises and particular learnings and theories that help people change the way they think and the way they do things day in and day out. The name kind of says it all. It's cognitive thinking and behavioral doing therapy. That's what it is. It's just a therapy. It's a set of exercises that helps you change the way you think and change the way you do things from day to day. It's actually a pretty simple kind of therapy. As someone who not only does it, but teaches other professionals how to do these kinds of therapies sometimes and supervises grad students who are learning these things, this is generally what we start them with. This is like the 101 version of professional helping stuff, and it's nothing to be intimidated by, even though it's got a big, long-sounding name. It's actually some of the easiest ways sometimes to resolve things that are going wrong. But beyond cognitive behavioral therapy, we always try and do something called BA, or behavioral activation, with someone who has depression. Because it's a disorder that impacts your entire psychology, including your nervous system, we know that part of the solution involves your entire psychology, including your nervous system. So a lot of people who are depressed, you saw the list of symptoms, they get into a pattern of not doing things because they lost interest in what they were doing previously, or because their mood is too low, or because their thinking is off and they can't think logically. They get into this pattern of sitting on the couch or sitting in their bed or being kind of stuck almost in a position. So behavioral activation is identifying that stuck component of their depression and helping them get unstuck from it. And so there's a million different ways we do BA and behavioral activation, and they look pretty much as different as people's depressions do from one depression to the next. But some of the examples I could give you of how we did this, I've done this with a patient who felt he was pretty much trapped in the house because he was depressed. He was sitting around on his couch all day. So part of his BA with me, his first week of treatment, was he had to get up out of his house twice a day and take a walk around the block. That was his treatment. And guess what? Doing that actually stimulates his nervous system in a way that's a little different when combined with some CBT, and the rest of his treatment begins to help his depression. We absolutely look at psychopharmaceutical treatment, which is medications that work on the brain. Okay? There are medications starting in the 1980s that have come out that have been proven to be very helpful for depression, but all the research and literature that we have today would tell us that we always combine it with, at the very least, a cognitive behavioral therapy. Generally, for most courses of depression, when the depression is mild or moderate, we usually don't start with a medication. We generally bring the medication out either as a second phase of treatment because we've tried something already like a cognitive behavioral therapy and it doesn't seem to be doing it on its own, or we look at it because the depression initially got diagnosed when it was in a very severe stage. Okay, so we would just start throwing a bunch of things at it at once. We look at other kinds of therapies as being helpful for depression too. There's all sorts of specialized therapies out there. You look at a counselor's webpage these days, you look at, something you read online about a helping professional, and you're going to basically just see a list of acronyms. They're certified in this, they can do that, they've got a license to do this, they're a specialist in that, they have extra experience in this. And all of these different therapies and certifications, they've all been kind of proven to be good for one thing or another. Some of them are good for this kind of stress, some of them are good for this kind of emotional problems. Well, there's a whole contingent of them that are good for depression. And you'll see lots of helping professionals like counselors or psychologists advertise themselves sometimes as someone who practices a particular specialized therapy that might be helpful for you. Your best bet here, this is where you use your Dr. Google skills, if anything. If you run into one of these technical therapies or specialized things and you're not sure if that has anything to do with depression even, Google it and find out. But at the very least, understand that there are certainly lots of them out there that have been proven to be helpful with depression as much as the rest of these are. And we actually, right in our medical textbooks, diagnose a prognosis for bad depression where we ask people to engage in additional spiritual and social community support. Because depression is so correlated with isolation, with feeling alone, with people not understanding you, and many of its symptoms make people disengage from their usual circles, their usual rhythms in life, we actually prescribe a re-engagement to help reverse the effects of depression. So this is what we do for it generally, and again, it's usually a mix of people like myself and doctors and any of the professionals who work in mental health who'd be doing stuff like this. So I'm just going to mention one more thing. This is, I always kind of like to tease people a bit with what's the newest, latest, and greatest when I'm talking. So in the last 10 years or so, excuse me, we've had a bit of a focus on a couple of areas in psychology, and one of them since the turn of the century has been an area we call positive psychology. Till the late 90s, in this study that we do of how people work, actually we largely only studied the problems, like how things could get broken, and then we've got stuff like depression, anxiety, and when, mental health and psychology, things aren't working. Well, a bunch of real smart guys got together and said, why haven't we studied when things are really working well? When things are actually going A-okay, how all these same measurements and functions happen. No one had studied it to this point in time. So they started to study it, and they called that end of the science the positive psychology. Like when things go well, same measurements, same things. Well, there's a particular exercise they developed in positive psychology called the 5 Good Things exercise. And if you're not familiar with this one, I thought I'd share it with you today, just as a little trick or tip you can have in your back pocket. You can go Google it later, kind of learn more about it if you'd like. They developed this one in conjunction with a really famous psychologist by the name of Martin Seligman. This guy was the president of the American Psychological Association for a while, but he really led the charge on researching this stuff to see if it works. His research into this, he did this on literally tens of thousands of people trying this exercise daily. And what he had them do is go through doing this psychological exercise, and he would go and measure what happens to things like all the things we talked about, right? People's emotions, people's thinking patterns, people's behavior patterns. Well, with a control study of 20,000 people, they found that when they did this little positive psychology exercise once a day at the end of the day, that any of those people who were just totally unrelated to the study happened to be depressed, this actually ended up helping fix their depression. So it ended up being one of these brain exercises that actually starts to reverse some of the thinking problems that comes along with depression. So this particular exercise, the 5 Good Things, is a completely simple do-it-yourself at home exercise. You get a blank piece of paper, you write numbers down the side of it, 1, 2, 3, 4, 5. And at the end of your day, you simply sit down, you close your eyes, and you play back your day like a PVR, just from the beginning. So you go through it and you think to yourself, okay, I got up in the morning, feet hit the floor, got to my shower, and you go through your entire day that way, and you look for 5 good things that happened during your day that you missed. Maybe by the time you get to lunch, you're realizing, oh my gosh, there was a sandwich there. I love that sandwich. It's my favorite sandwich. I blasted through my lunch so fast, I didn't even stop to enjoy my sandwich. That was like a good part of my day, and I almost passed right by it. And this doesn't have to be lightning strike things. This doesn't have to be the world's best and biggest things that make us dance for joy. It can be just little micro drops of goodness like that, like your favorite sandwich. Or getting an easy parking spot next to the store. You don't have to walk across the whole bloody. Okay, those little things, sometimes when we're in a hurry, we just blast by them in our day. But by going back and rethinking them at the end of the day and writing them on a piece of paper, what you do to complete this exercise is you just write one thing beneath any of the good stuff you could find in your playback. You write down what you did to make that good thing happen. Because when you're depressed, this is actually one of the thinking functions that stops happening in your brain. Your brain stops making the connections between good things and yourself. That's part of what depression is. And they found a simple little thinking exercise you can essentially put yourself through that starts to reverse the effects of depression on the brain. It's a beautiful little exercise, and because it's so simple, it's one that I share with so many of my clients and patients because they can take it home and do it themselves. No drugs necessary. Isn't that lovely? But to that end, positive psychology could be mined full of these little exercises that are applicable. As I say so oftentimes, this is not the end of the conversation. This is probably the open door or the beginning of what else is there that you don't know about. So we're going to break here, and after our break, we're going to come back and keep chatting a bit about anxiety and how we can help ourselves and help others. It's about 1:55, so let's try coming back together at about 5 after the hour, so in about 10 minutes, okay? So grab a coffee, grab something to eat, and we'll continue the conversation. We're going to resume our conversation, kind of moving on to another area of mental health that is widely called anxiety, okay? So we're going to talk, much like we did with depression, a bit about what anxiety is and how to understand it to begin with. So the first thing we want to kind of present to you and help you to understand and swallow a bit more is anxiety actually has a lot to do with your physiological body. The whole issue around anxiety is actually built on top of the way your body's supposed to be functioning healthily. All right, so your body has a series of natural systems and states within it that actually is designed to protect you. If you could think about an ancient agricultural society, they're out in the fields farming their thing, getting their food for the winter, and all of a sudden, let's say a giant bear runs out of the woods towards their little agricultural farm. Well, your body is actually designed to respond to a threat that way. And what it's meant to do is a piece of your body called the sympathetic nervous system kicks in and it heightens your muscles and your vision and your blood pressure and all these things. So potentially you could run away from danger. You could protect yourself from the bear. And what anxiety and its subsets essentially are is those systems in your body getting stuck, turned on. Okay? When there's no bear, when there's no danger, it's your body telling you there is. If those anxiety systems, those warning systems were like a fire alarm, it's like the alarm's going off when there's no smoke. Okay? So, contrary to popular belief, we use the word incorrectly, I think, quite often, but real anxiety, mental health anxiety, is very separate from your regular fears or momentary or environmental panic. I have a young daughter, and she is not very good at sensing dangers around her. It's actually something we know about her. And to that end, we feel that quite often this not quite 3-year-old needs a lot of supervision, a lot of hand-holding, a lot of you don't go in the parking lot by yourself. Well, you know what? If all of a sudden she slips her hand out of mine and makes a mad dash for the road, I panic. My heartbeat goes through the roof. That natural defense system kicks in, and that's legit fear and panic. That means I'm healthy. It means my body's doing what it's supposed to do in a threatening situation. Okay? That is very different than anxiety. We all have those moments throughout our life and throughout our days where the fear or the panic or the something goes up. That doesn't mean you have anxiety. Anxiety is when you have that kind of reaction for no good reason. Okay? So, one of the things we want to highlight for you today, this word anxiety is pretty crazy because actually it's not really a thing. There's no diagnosis of anxiety in any medical textbook or psychology textbook or anything like that. There's actually a whole umbrella grouping of what we call the anxiety disorders, which are actually all largely different and separate from each other and work completely differently. However, how they look similar is many of their symptoms overlap. Okay? And so we call it, the difference between presentation and symptoms is presentation is what happens during the course of anxiety, and symptoms is what you feel or what you experience during it. Okay? Most prevalent childhood mental health disorder across the globe, anxiety. So especially children between the ages of 6 and 15, this is the number one concern for pediatric mental health. Okay? Hugely reported in Canada as a problematic thing. All right, so let's take a look at some of the numbers. So we did this big community health survey by StatsCan just a couple of years ago now, 4 years ago, and we found all sorts of things. There were more mood disorders and anxiety disorders amongst females than males in the population. And so we found this out and started to do research and discover things about it. Youth in the older age category, the adolescent age category of 15 to 24, met more criteria for either depression or anxiety than any other age surveyed. That says something about the snapshot of Canada in that period of time. It says that actually maybe depression and anxiety are happening way more often in people who grew up after being born in the year 1990 than it is in other generations. okay? Anxiety disorders currently, so at the time of this survey, affected 5% of the Canadian household population. That's a huge number. That means roughly in 2012, if you knew 20 people, one of them in their household, there was an anxiety disorder. 10 to 20% of Canadian youth are impacted by mental illness at any given point in time. And of course, as we talked about, anxiety being the big one there. And 1 out of 5 youth currently in Canada who actually need mental health services, they're the big age category who are experiencing this stuff, only 1 out of 5 of them are actually getting mental health help with this. That means 80% of the people in that age category going through this are not getting the help they need for these kinds of problems and disorders. These are shocking numbers. These are horrific, right? Definitely worthy of at least being aware of and being able to talk to people about.
Is that because they're not seeking it, or is that because it's not readily available?
It's a great question. So the question was, is a number like that because people aren't seeking help, or is it because the help is not readily available? And so the research in this particular instance doesn't specify, okay? It was more of a survey done just to report what's happening. However, we have other research and trends that we follow and governmental things that we study that show us that the answer is likely a little bit of both of the things you suggested. Is that, largely like depression, because of the things that come alongside of having anxiety, people are reticent to seek help sometimes. There's some guilt and shame that comes alongside of it because they, think it has something to do with being crazy or a misfire or something like that. Or that they're not able to access the help necessary. And there's a pretty big push, not just at the federal level in Canada, but provincially, province to province in Canada right now to address mental health in a different way. So, great question though. So, I mentioned anxiety, when it comes down to it, is really a catch-all phrase for a bunch of really different disorders. So before I turn our time over to Kelsey today, I just want to highlight what some of these are. We're not going to look at them all in depth, but to kind of give you an overview of what we're talking about in the realm in which we're dealing with anxiety. Then we're just going to shortly look at a couple of the things we do to treat some of these different disorders and anxieties, and then we're going to look more in depth at how to help ourselves and each other. So the most common form of anxiety is something we call the GAD, or the generalized anxiety disorder. And actually this is probably the reason why anxiety is usually used in language like this, because so many people are referring to GAD when they use a word like this. Generalized anxiety really is what it sounds like. It means you're just generally anxious. You've got that fire alarm system going off for many different reasons all the time. So much so that we consider it disordered, okay? We have something that's called health anxiety that I actually run into a lot in my practice out of the public health care system. I deal with people I mentioned with a lot of chronic diseases and chronic pains, and actually about 70% of the people I see in that setting end up reporting having health anxiety, where the thing that sets their fire alarm off more often than not is not knowing what's going to happen with their health next. When's the next time a pain is going to flare up or a disease is going to, take them out or inhibit their function? And they start to think and kind of ruminate on that so often that it turns into an anxious pattern for them. There's hoarding disorder. You may be familiar with this due to some popular television or lifestyle programs that you may watch. But hoarding is an anxiety disorder where essentially people have this fire alarm going off, and their soothing mechanism involves controlling their environment with extra supplies, with things that they don't want to lose, things they want to have access to, so they can essentially turn that alarm off and make themselves safe. Obsessive compulsive disorder you may be familiar with because of the media as well. Oftentimes this is one of the most maligned against or kind of misrepresented mental health diagnoses in the media. People often get portrayed as kind of being insane or crazy and having little twitchy movements and, having to run to a light switch and flick it on, flick it off, and all this kind of stuff. Obsessive compulsive disorder is actually just a thing where someone who's anxious brain tends to work in patterns. And in order for them to feel better, their brain also needs to respond in patterns to their environment around them. And much like the hoarding disorder, what people end up trying to do is control their environment. But rather than control it by hoarding extra supplies and things that will make them feel safe, they try and control their environment by usually some kind of self-care behavior where they wash their hands multiple times or they organize things so that their feeling of comfort increases. So OCD is about these compulsions to do these things and the obsessing around doing them correctly and rigidly the same way each time. Panic disorder and agoraphobia kind of go hand in hand because we rarely see one without the other. They are technically two different disorders, but honestly, we've only ever seen them come together. And panic disorder is when people tend to have what we call a panic attack, and we're going to look at that in a second. And oftentimes it can happen when they leave their home or their safe environment at work or something like that. So agoraphobia refers to fears of kind of leaving a space or going outside or wider areas, things like that. And you'll hear people with anxiety often talk about feeling like they're too pressed in or like there's too much around them. Post-traumatic stress disorder, or PTSD, is another form of anxiety. Oftentimes this is associated with military personnel and combat veterans. However, it actually most commonly occurs within family and household settings, usually around minor family traumas like car accidents, or even for kids and teenagers, things like moving homes or schools or towns. Basically anything that upsets your expected natural order of things. And that's how it ends up impacting combat veterans and military personnel, of course, because the scenarios they come in contact with in active combat are so out of the ordinary compared to what their brains expect. But again, can provoke these anxious reactions where people kind of relive their traumatic experiences or car accidents or combat, or they have dreams about it or flashbacks, and that sets off this fire alarm again for them. Social anxiety disorder, similar to generalized anxiety disorder, this one comes up all over the place, but it generally comes up with regards to your social relationships. So the things making your fire alarm go off are generally the things that involve you having a social commitment or having to do something with other people a certain way or certain types of people, so on and so forth. Separation anxiety we often see with children and sometimes with teenagers, but also with adults as well. This is when the physical separation of relationships and people tend to provoke this response. A lot of parents miss this in younger kids, thinking that it's just a kid throwing a tantrum or that they're being bratty or they just really miss their mom. But actually at a certain level, this is a nervous system disorder. This is something misfiring inside their brain and body, and we actually need to address it. Specific phobias, from time to time you'll find people who say, oh my gosh, snakes just set me off, or spiders, or flying, or heights, or falling, or you name it, and we can probably have a phobia of it, and actually this is just a very particular type of anxiety disorder. This is your brain essentially turning on that alarm system again and not letting it go, even though you're relatively safe. Selective mutism is an interesting one that I always tend to get into conversations with because I think it's not really well represented in the public mindset, but believe it or not, it's actually quite common. Usually happens in younger kids and school-age children, but it's when anxiety gets to a level where people actually can't talk. And maybe it's just situational, so maybe it's at work, or maybe it's at school, or maybe it's at home, and that's the only place they can't talk. But actually they get so overloaded that the part of your brain that usually controls speech doesn't turn on. Okay, so selective mutism is another one. And the final type of anxiety disorder that comes up for people are the BFRBs, or the body-focused repetitive behaviors. And these particular types are when people tend to be into biting their nails or picking their cuticles or eating their hair or picking their skin. And again, there's a number of things that can kind of fall under this category, but it's the same idea that there's an alarm going off that they're trying to soothe. And the soothing mechanism in this case is actually control over their body. It's quite a complex set of disorders. So as you can see, all sorts of things fall under this umbrella term of anxiety, and really they can be as different from one to the next as we can describe them. So what are we looking for then? A professional like me, just like we talked about with the depression, we look for specific signs. Because anxiety is a much wider umbrella than depression is, the signs we look for tend to be that specific, more at the disorder level. So if I'm looking for the signs of OCD, or I'm looking for the signs of PTSD, just like depression, I've got a list of 5 things or 9 things or 7 things that I'm looking for. But when it comes to anxiety in general, we also know why we call these the anxiety disorders is that all of the disorders, no matter how they play out, share a few common signs because they all come back to that body systems that are misfiring. So age specifically, in toddler and preschool kids, what we look for is distress in anticipation of separation. Okay, so if kids start getting freaked out before you leave them with the babysitter, or before you head out the door to go to school, this is actually a sign. If they get freaked out when you get to the school or when you get to the babysitter, that's a little more normal. We expect that in a kid. But if it starts happening ahead of time, we watch out for that because usually kids don't actually think ahead of time. So the fact that they're doing it in this case really means something to us. Okay? Nail biting, stomach aches around separation, other signs we watch for in kids this age. Nightmares, or if they start playing games or have worries about separation in their little play with their friends or with their toys, or if the things they play with their toys are about leaving and separating, we watch those sometimes. And similarly, any kind of excessive worry about harm coming or to a caregiver or losing a caregiver, you're never going to come back, what if something happens to you, something like that. These are the kinds of things we watch out for kids. And we can actually see these kinds of disorders come up in kids as young as 3. School-age children, we actually look for quite different things, okay? No matter which of these disorders we're looking at, we're looking for reports of illness, headaches, stomach aches, especially around school attendance. When it's time to go to school or time to go to clubs or time to go to, soccer or whatever it is, truancy or worry about attending school, separation anxiety, so again, having to leave mom and dad and that becoming problematic, nightmares, night terrors, bedwetting or reverting from a potty-trained state to a non-potty-trained state. These are all things that we watch for in kids as signs of anxiety. For adolescents, we look at, again, for quite different things again. So we think teenagers on through till about the age of 25. We think about behavior change, sudden or rapid or marked behavior change. Social withdrawal is a big one. People who get anxious tend to spend more time trying to bring themselves back down, and they tend to do that alone so they don't get set off. Academic troubles or truancy again, eating changes, weight loss and gain, again, anxiety, especially because adolescents are so connected to their eating patterns and their digestive system. This is where we see it fluctuate the most. With adults, we tend to look at pretty stereotypical what might come up with the picture of anxiety in your mind symptoms. So we look primarily for the symptoms of a panic attack and then the generalized worry. All right? So panic attack, which comes along with panic disorder specifically, but can come with lots of other kinds of anxiety for adults, we look for a physiological moment where a lot of people mistakenly go to the ER because they think they're having a heart attack. That's what it feels like the first time many people are identifying having an anxiety or panic attack. So they get a racing heartbeat, they sometimes get pain or numbness in their extremities, they get racing thoughts, and they can hear their heartbeat in their ears. Oftentimes there's a lot of discomfort that comes with this. And so in a panic disorder, this is the kind of thing that's happening for someone multiple times a day. For a panic attack, this can come along for an adult or some older adolescents with any form of anxiety. And we watch out for these physical signs along with the types of cumbersome worries and nonsensical thinking about threats that we described earlier. So, understanding there's so much under that umbrella of anxiety, what can we do about it? Well, much like depression, the number one treatment that actually works for anxiety is something, again, called cognitive behavioral therapy, and I won't take the time to re-describe that to you. But other talk-based therapies or counseling therapies, believe it or not, are the number 2 treatment for anxiety after CBT. So a lot of people are surprised to hear this because, again, working with a family doctor, and I work with family doctors all day. I love family doctors. I need them in my world. But depending on the generation in which they were trained, they might have been trained in a generation before some of these other therapies existed. And if that's the case, there are medications around that we've used for anxiety for quite a long time. Medications called sedatives, as well as there's certain medications, brain medications we use for depression as well, that can also be useful for anxiety. However, even more so than these medications, we often use a form of family therapy to treat anxiety. It's actually one of the most effective forms of bringing anxiety back down for people, because oftentimes in a family setting, you can change more than just what's going on for one person. You can change other sources that might be impacting anxiety-provoking behaviors. And we also use a type of intervention called physiological relaxation to treat anxiety. And when I say this, a lot of people get a picture in their head of, kind of sitting in front of Netflix and chilling out for 10 hours and eating a lot of chocolate or popcorn or something like that. This is not the relaxation I'm referring to. This is actually more about how your nervous system works, that piece that's getting all fired up and turned on and locked in and stuck. We can actually teach people certain exercises, behaviors, ways of changing their thinking and their body and their muscle flexings to actually reverse that effect, to introduce a slowed down nervous system into that heightened state. So this is called relaxation or regulation therapy. And so teaching those physiological relaxations is a big part of treating anxiety sometimes. And then we use something that is gaining a lot of popularity again in the 21st century. It's called mindfulness. And we're going to talk a bit more about this in the Q&A. So, other specialized therapies that come alongside this, much like depression, you're going to run alongside people saying, I do this particular certified thing and this specialized thing. And again, there's a bunch that are just designed for anxiety and those particular disorders. And if you're unfamiliar with them, this is where Google becomes your best friend. I threw a title of a book in here just because I do work with parents and kids an awful lot. And this is probably, if you're a parent and you have a kid with anxiety, the best resource you can find. So Reed and Lynn, Reed is a doctorate psychologist, Lynn's a social worker, they're both out of the States, wonderful people I happen to know in my line of work, but they published this book a few years ago, and since this point in time, there have been anxiety treatment programs all over the country, in Canada and the States, that have actually started using this as curriculum in pediatric settings. So parents, do yourself a favor, and you're looking for some tools for yourself and for your kids, is a good place to start. So relaxation therapies, the regulations, I'm just going to say a word or two about them. You've probably experienced these somewhere. You've heard someone say, learn some breathing exercises, do some meditation, try some yoga. Have you done this kind of mindfulness thing yet? Well, all of these various activities fall into what we call regulation or relaxation therapies for your nervous system. And like I had indicated in the previous slide, they're essentially designed to turn the volume back down on your nervous system. So when things were amped up before and sending off that false alarm signal, this can be like the mute button a little bit if you can learn which ones can help the kind of anxiety that you're experiencing. Well, I think that's about enough for me. I'm going to invite Kelsey up to talk a little bit about helping each other and helping ourselves, and even looking at the kinds of practical resources that are necessary to deal with some of these mental health things. Kelsey.
Hi, everyone. Thanks, Joel. So I'm Kelsey. Thank you. And I, probably like many of you, have sat through these and go, okay, so now what? So my part of this presentation this afternoon is looking at the practical stuff. And to encourage you, it's not rocket science. You're probably going to look at this and go, really? That's what I have to do? But just want to encourage you. So to start off, Joel mentioned it earlier, there is still a stigma, I think, around mental health. So yay for you guys for being here and breaking some of that stigma by being able to talk about it and learn about it. I came across this cartoon. I think Joel had it in one of a slide previously that I saw when he did a presentation, and I really like it. I think it's quite funny because there is still this idea that mental health is similar to like a physical ailment. So just take a pill, just do something, and it'll be really easy. So if you look at some of them, I don't know if you can read it, but one of the first things is, I get that you have food poisoning and all, but you have to at least make an effort. And I think sometimes with mental health, we just, try to do that. Or you need to change your frame of mind and then you'll feel better. And the poor guy's standing there and his hand's cut off. I mean, if we started doing that with physical diseases, that probably wouldn't be very helpful. So I'm hoping today to give you a little bit of tools that you can take and try to encourage you and remind you that you probably are already doing these in your life. But yeah, let's take a look at it. So the practical tips. Learn more about mental health issues, which is what you guys are doing today. So again, check that off your list. Good job. Learning about it, knowledge is power. The more you know, the more you can kind of understand either what someone in your family is going through, what maybe yourself is going through, and it kind of makes it a little less scary, a little less daunting. Another thing is recognize how emotional it can be. For someone who is experiencing a mental health issue for the first time, this is going to be a little nerve-wracking, and there can be a lot of emotions involved with it. And even as a family member or as a friend, there's a lot of emotions going on for you as well. They could be anything from guilt, shame, kind of wondering, how did this happen? But then there also could be that other side. If they get a diagnosis label, there can be this relief to know what's going on and that there's a plan and how to do it. So being able to give space for these emotions, recognizing that they're going to come up, is also a great tool that you can use. And balance support. So what this means is, oftentimes I think with mental health or when someone is struggling in our life, we want to come in and be like the savior, like the Superman or Superwoman, and try to do all and be all for them. And the truth is, that's not great in the long run, because you're going to burn yourself out and they're not going to learn how to do things on their own. And that's the thing we want to push, is that they still have a voice and we want them to be their own advocate. So helping them through the process is great. But also learning how to take care of yourself as well. Learning what supports and resources are out there for yourself so that you can get some help and talk through what this process is like. If you're a parent and your child is getting a diagnosis or having some issues, what's going on for you, and having that support so that you can better able help them in the long run. And then practicing self-care fits into that. So choosing to, not do the dishes one day and get down on the floor and play with your kid. Learning to check out and watch Netflix for a little while. Learning to advocate for yourself. And then also teaching them. One thing I'm learning as a parent, I have a 2-year-old, is that the patterns that I start in terms of self-care, he's going to repeat. So if I'm going, how can I expect my child to learn how to stop and take breaths and really learn how to take care of himself? Because we do live in a city that's go, go, go. And this is something that I think we all could use a little touch up on. So especially if you're dealing with a mental health issue in your family or with someone, being able to recognize, I need to stop, I need to take a break, is a good thing. And find resources in your community and for you. And again, I'll give you a list, but those are really helpful. Build a net. Friends of ours recently just experienced a loss of their mom due to cancer, and she's an amazing writer. She's writing this blog, and she's talking about her experience about when the bottom fell out, and she was shocked that there was this net to catch them. And so that's part of it. You don't need to be the whole net, but being one part of that net, and then helping build that net so it's stronger to catch them when the bottom does fall out. And listen. Now, this may seem easy, but I think a lot of times, especially in church, if some of you have a church background, we try to find the right answers, or we're always trying to feel like we need to be the experts. But sometimes you just need to listen and to give space. And so, in a little bit of humor, I found this amazing resource. How many of you guys have heard of Brene Brown? Yeah, a few of you. She's got amazing TED Talks. If you go on YouTube, there's tons of resources. She's a social researcher, and she has this little short about empathy versus sympathy. And we're going to watch it and talk a little bit more about how to be more empathic, how to really lean towards that side versus the sympathy side. So we'll play that video for you guys now. So that idea of being there, and that we don't always have to have the right words to say, but that it's, wow, that's deep, that's hard. I'm sorry you're going through that, and thanks for telling me. Because I think as human beings, we are designed for relationships. We want to know that someone is in this with us, and that's the biggest thing I hope that you can take away from this is being there with somebody who's struggling with mental health issues is huge. We see that a lot in our jobs. We get the privilege of being brought in and hearing their stories. And as a friend, as a family member, as a support person, to someone who's going through mental health, or even for yourself, trying to find that person that can be in the pit with you, I think is an amazing gift. So I hope that this encourages you to just remember that, if nothing else, to look for those moments where you can find connection. So resources. This is not an exhaustive list. Dr. Google is also an amazing tool, like Joel said, but here's just a few that I came up with and then thought of more on the way over here, actually. But places like Collaborative Care Network. So finding people that are trained in this. Again, you don't have to be the expert for mental health stuff, but helping them get connected with someone who can get them the resources and get them the help that they need, and is helpful. If you write any phone number down, this is probably a great one. The Distress Center has a 24-hour crisis line, and it will connect you to a trained counselor any time of day. So especially if you are dealing with someone who could be suicidal, or you're fearing that they could harm themselves or others, this is the number to call. So it's 403-266-HELP, or 4357. So write that down, have it in your back pocket. It is probably the best tool you can have for 24-hour help, so that you don't feel like you have to carry it on your own. There's also Access Mental Health. Again, you can look up in the resource. I think it's run through AHS, correct? And so they can connect you to things like for assessments and, again, to healthcare professionals. And then here's just a list of some other big services that will can provide counseling services. So Woods Homes for families, Catholic Family Services, Calgary Counseling Center works on a sliding scale with different professionals and resources, Hall Services, Cara, and the Alex is a great resource for youth. I've had experience with them in previous jobs, and they're just great for coming around and providing support for youth. So that's there's also Kids Help Phone for little guys. I forgot that one, but it's another great resource, and it's on like Smarty boxes and stuff. So when your kids are going trick-or-treating, just write down that number. And they can call themselves, and it's great support for young ones as well. But I think that's my time. So we'll head into that Q&A section.
So what we're going to do, Kelsey and I, for just the next 10 minutes or so before we finish up here today, is we really want to turn the time over to you. And so we recognize that a presentation like this is going to generate a lot of questions and maybe, new thoughts and ideas. And so part of what we've provided is having Pastor Joel equipped with a microphone, and he's even going to basically come to you if you've got a question, and you can say it into the mic and people can all hear it. And Kelsey and I are going to take some time to see if we can continue the dialogue with you guys. Go ahead, throw your hand up. Joel's a little scary looking, but he'll bring the mic and leave you be. It's all right. A few over here.
Hi. Thanks for the resource on the anxiety in kids. I'm looking forward to reading that book. Could you just spend a couple minutes chatting or talking about, as a parent, working with your child who may be higher on the anxiety spectrum, maybe not on the disorder side,
Sure,
but
sure.
how
But
we-
lots there.
Yeah.
Yeah. So I'm going to probably have Kelsey say a little bit about this too, because she's got some really great skills, both personally and professionally, with young kids. But to this end, my favorite thing to talk to parents about is this whole monkey see, monkey do phenomena that you end up learning about when you have kids. So this is not somehow a critique of parents. You did not make your kids anxious. But when it comes to learning new things, like how to treat and solve anxiety, you were probably your child's first line of defense in teaching them something new. So even if you're not an anxious person yourself, your best bet in working with your kids is modeling somehow what calmness would look like. A lot of people think that the other end of anxiety is somehow being neutral or somehow just being okay day to day. The other end of anxiety is actually calmness. It's actually peacefulness, and it's something that we don't all achieve, a lot of us day to day, even when things are kind of neutral for us. So you'll find this in the book that I kind of pointed you towards as well, but the idea of modeling a more calm interaction with the things that are setting off your child's alarms, and being patient and knowing that this isn't somehow them being bad or willful, but again, that this is probably going off inside of them and they can't control it either. Yeah. And what would you say maybe to add to that, Kelsey, if anything?
I think the biggest thing as parents is creating a dialogue that it's safe to talk about what they're anxious about. Again, by even modeling that behavior of, wow, I'm really anxious about going into this meeting, or just so that they kind of get familiar with it, that it's not so much a scary thing to talk about or something that they need to keep private, but that it becomes part of your family culture to talk about it. And because when we say it out loud and bring people in, I think it makes it a little less scary for kiddos.
It's one thing that counselors and psychologists are very good at. It's part of our job. It's called normalizing, and they actually teach us in school how to do this kind of stuff. But we want people to be able to bring their big, hairy stuff to us, and for us to be able to talk to them like, that's okay. That's normal. We can talk about that. We'll handle that together. And that actually brings a sense of calm and, a downswing to that anxious nature, and parents can replicate that with their kids. It's great. Other questions? I saw another one near the back, I think back there, and another one up here.
Yeah, I've got a question about family connectedness.
Yeah.
And with young adults who don't want to be connected.
Yeah.
Now,
That's a great question.
Okay.
I've heard about 18 variations of this question, probably from about the last 19 families I worked with young adults who didn't want to be connected. And so, not to put words in your mouth, but I'm guessing the concern here is that the parental system says, this is what our family should look like, and then the young adult child system says, I'm not interested in your particular version of that, I'm going to go do my own thing. Is that? Beyond that even, yeah. How to orchestrate things going forward into the future, and yeah. That's right. Yeah, what's going on and all this kind of stuff. So there's a lot of intricate questions and pieces of this. Some of this exists within the legal status of humans as adult decision makers in the medical system. Other pieces of this are going to be cultural norms about what's regular for some families versus what regular is for other families. But this idea of connectedness comes up usually at this phase of life. My other area of specialty, aside from the health end of psychology, is I do a lot of marriage and family therapy. So I work a lot with family systems and couples and parents and so on and so forth. And what I see most often is actually the two most common places where family systems fall apart is generally when kids come into the picture and when kids are trying to be launched from the family. And oftentimes, it's around health issues or mental health issues that actually stimulate some of this within the family system. And so the question about, what do we do about it? The answers are probably as complex as the problems. There's not a standardized answer because there's not a standardized problem with families here. But some of the things we pay a lot of attention to in these areas are certainly about how can we maintain those measures of good mental health. I talked a little bit about that positive psychology end of things. Well, there's a whole end of that study about how relationships should work, how families should work, how they should work when kids live in the home, how they should work when kids live out of the home, so on and so forth. And knowing that there's certain ways to do that kind of stuff, you can work with a professional to help your family go in that direction. This is where family therapy comes into play sometimes, as weird as that sounds, but there are professionals who are trained to help your family relationships. Now, does that answer some of your question? Or I know the bigger question is, can I make a professional give me information about my kid's health care, right? And honestly, the legal answer here is no, ultimately, because of how privacy laws work and how medical information laws work. The up and down of it becomes, I loved Kelsey's comment about how to deal with kids and anxiety, because creating that open dialogue within the home environment, I think, really gets around this problem. Because if there's a potential to increase the ability to talk openly within a family system of stuff like this, it's really independent of the issue of who controls the health information, because as a family, we can all come together and talk about it. There's another question back there, and then one up here.
So this is kind of in relation to, I guess, the social economic status and pharmaceuticals.
Yeah.
And also connects a little bit to the last question.
Okay.
So growing up, I had a very close friend who didn't have that family support.
Yeah.
It was a dysfunctional family, and she couldn't really rely on that communication and support.
Yeah, lots of those in this world.
Yes.
Yeah.
And what I'm kind of wondering is that, do you think there's any relation between the social economic status and what might be available in terms of finances? Because with like the pharmaceutical company, it might seem easier to just give someone a pill.
Of course.
And find that to be the solution, because maybe they can't afford counseling or something like that, or they're not educated in what is available to them.
And what's available and whatnot.
Right.
Do you want to say something to this first, Kelsey?
I don't know. I mean, it's disheartening if you've worked with anybody in a population that they're below the poverty line and they're struggling to find resources. But Calgary Counseling Center is a great place for people to go. There's students there, there's people that are working on sliding scale to kind of create that dialogue. And I think, yeah, I mean, it's a struggle until our culture kind of catches up with the idea that mental health is just as important as our physical health. It's going to be tricky, but I think by equipping yourself, knowing what resources are out there, there is some steps that we can do, I think, to help.
Well, and I think, this question is prevalent for our current context, right? We're sitting here in a church on a Saturday afternoon having a 2-hour community seminar on mental health, and that's not to say that this doesn't happen in the public healthcare system. I give these talks in the public healthcare system as well, too. But the reasons that an organization like a church is going to step up and do something like this is because they can also see the need for this kind of conversation. It comes back to the idea that Kelsey said, that in our society, there needs to be more talk about this. And I think we've hit the critical tilt. I think even in the last 5 years, 10 years, I even remember in the late 90s, early 2000s, mental health was still, you don't talk about it kind of stuff, that kind of stigma. At least in this day and age, we can say the words and not everyone turns it into a joke, and it's a little more familiar that way. But a big problem becomes for the low SES folks, I think, is what the healthcare system offers. Our healthcare system in Canada, if you don't know your Canadian history, was roughly designed in the late 60s and early 70s as a movement out of socialism in Manitoba. And so we set up our healthcare system in Canada to largely account for medical doctors and prescription pharmaceuticals, but this was a day and age where we didn't have other healthcare professionals in the hospitals, like psychologists or counselors or whatnot. And while we've made some changes to this system over the years, this is largely the same system we're dealing with today. So we run into interprovincially different, funding issues, different, one province doesn't have publicly funded counselors, another one you can only access them through a hospital, and so on and so forth. And this is why if you read the news and you search mental health in the news, all you see is the arguments between the premiers and the prime minister about where the money's going to go and when it's going to come and because mental health is on everyone's mind. You know, I appreciate your question too from a personal standpoint, because I actually come from a very low SES family myself. You know, growing up, I don't mind sharing personally that we were the family that had to take food from the food hamper and, get that kind of stuff. And I certainly grew up in a day and age when we didn't know what mental health was. And it intersected with my life and my family's life in many ways. And to that end, even kind of began to fuel what eventually became my passion for helping people with mental health things, is understanding how valuable that help can be. So, long answer to your short question, is it a problem for people in those categories? I think the answer is yes, but I think it's more complex than just a straight yes and no, problem, not a problem. It's so many moving parts here. Yeah. Thanks for the question.
So you brought up at the beginning ideas about stigma, which I'm glad that, of course, you touched on that. My question is surrounding how within faith, spiritual church communities, there's a different kind of stigma.
Yes.
And I was kind of hoping you could touch a little bit more on that. And
Absolutely.
I mean, I don't know what your experience is, but even people talking to you about that, I'm sure there's certain rhetoric that's come up. And because I think the fundamentals of listening and empathy and those things those go across anywhere, but the tension of faith communities and mental health, I think there's still a huge gap there. And I'm wondering if you can speak to that.
And faith community, we're probably using it as a very generic term here, because that's a broad stroke, right? Different streams of faith are going to interact differently. But Kelsey, maybe you say something about this.
Yeah, at my church, we're doing a short-term small group on emotionally healthy spirituality, and so it kind of connects with that. Like, how do you bring the psychology with the theology? Because I think sometimes in church history, we've used theology to kind of diminish seeking help, or, oh, you have anxiety, well, you must not have enough faith. What are some other ones that I heard? Because people were a little nervous when they heard that I was going to be doing this small group. They're like, are we just going to perpetuate those kind of mistruths that I don't think fit with the God in our Bible or Jesus or the theology that he wants us to have in terms of loving those with mental health issues. I could go on for a while, but I think the biggest thing is trying to understand that our theology, that God does care and he sees that, and he's the God of redemption. And so focusing on that piece, I think, would be really helpful for those suffering with mental health issues. And read this book. I mean, it's written by a pastor. He's gone through his own emotional unhealth. It wasn't maybe
Which book?
Emotionally Healthy Spirituality.
Okay.
Because I really like the journey that it goes through in terms of looking back at your past and understanding the history that you've come from, but then also how does God then meet you in those places? And the Bible study looks at different characters in the Bible. So we were looking at Saul, we were looking at David, just like some of the family lies that he was being told, or mistruths that were being told to him when he stood up to Goliath. But then also looking at Joseph and his family. So he was mistreated by his family, and then how he came back and showed grace to his brothers, and how emotional unhealth would probably be like revenge. And he kind of came in and showed them grace and viewed it as God's plan, and how God redeemed the bad stuff that happened in his life and gave it a purpose. And so how do we reframe that and restructure it to give it a purpose, as opposed to just completely dismissing it, ignoring it, or being scared by it, I guess.
Well, maybe to validate your question a little bit too, this is not the first context or the first century where the church has had a problem with a specific idea or a people group. There was a point in time where Christians, as good people as they were, used to burn people at the stake for thinking the world was round. And there was other points in time where, Christians would attack and murder those who didn't pray the way that they thought you ought to pray. And throughout, I think, history, with different cultures and different contexts, we could probably pick apart different examples where faith and the faith communities engaged have failed us in a good human response. And one of the interesting things about mental health that I mentioned at the beginning is a lot of it is based around language. And one of the things that's unique, I think, is that we've only really in the last 50 years developed the mature language we have now for mental health. And that language was certainly not in existence nor in use during the phases of time where the Bible was written. That's not to say that, like Kelsey's giving us an example of, you can't find examples of mental health in the Bible. You probably just won't see the phrase mental health in there because of the way language has evolved and how we put words together these days. Yeah, great question though. But to validate what you're saying, absolutely, the church has screwed this up so many times in the past. And that's, again, why we're so grateful to be part of a conversation like this today at KCC, because we just, as, helping professionals, see it as a great way that faith is interacting with mental health in the 21st century. To that end, our time is up. We know there's more questions. We're not going to leave you hanging. What we do want to do is honor your time, though, and thank you for being here with us between 1 and 3 today. If you'd like to hang out, chat with us a bit about what we present on, please come up and chat with Kelsey and I. I'm sure Pastor Joel will be around, too, if you want to talk with him about this particular church, KCC, and anything they do beyond Weekend University. Thanks for attending today, folks, and have a great one.